Yes, yeah.
Okay, thank you very much, sir, for your kind introduction to me. It's my great privilege and honor to present my case in front of such august gathering in this session. Honorable Chairperson, respected panelists, and learned audience, very good morning to all. First of all, I pay my deep respect and feelings to the person who have died in this corona crisis. And my today's talk is Majesty of Echocardiography, where life is on the road. My patient, a 65 years old gentleman who was diabetic, hypertensive, autosomal dominant kidney disease, polycystic kidney disease. He presented to our emergency with a history of fever and cough for 10 days, followed by progressive breathlessness and central chest pain for on day. Initially, he has been worked up at home and diagnosed case of severe COVID-19 on the basis of RT-PCR positive and ASCT showed the bilateral ground glass opacity, along with blood picture revealed lymphopenia, high CRP, ferritin, and D-dimer. This is the ASCT on the done on the 7th day show the bilateral ground glass opacity almost 50%. In our hospital emergency when he attended, he was conscious but unable to complete his sentence as he was severely dizzy. He was cyanosed, hemodynamic was unstable, respiratory rate was raised, JVP raised, and very low oxygen saturation, around 60%, but there was no sign of DVT and peripherals or cold. All on a sudden, he underwent cardiac arrest and fortunately reverted back by giving effective CPR and DC shock. After reverted from arrest, he was put on high flow oxygen, fluid, inotrope, and rapidly necessary sample was sent, including serum troponin. In the meantime, a 12-bill disease was undertaken, which shows the S1, Q3, T3, and V1 reveals the complete RVV. This is the McMinn sign. And by seeing this ECG, and we urgent focused echo, bedside echo was undertaken. This is the first view in the left external long axis view, showing the RV is usually dilated with small LV and with normal bulb morphology. And this is the diastolic measurement during the diastole of the RV and LV, showing the RV is 37 and LV is 21 millimeter. And this is the external short axis view and the papillary muscle level, showing the LV is T-shaped, indicated the pressure overload, RV pressure overload with minimal pericardial effusion. And the LV systolic function assessment reveals the concentric LVS, good LV systolic function. And at the peristernal short axis, we are the level of the great vessel showing there is a large thrombus in the main pulmonary artery, almost occupying the whole of the circumference. And this is the zoom view, and the measurement reveals 33 into 20 millimeter. And unfortunately, some color Doppler picture is missed. So this is the only colorful mapping in the still picture showing the very little color passed across the lesion, and tricuspid regurgitation was seen, and the velocity TR velocity 3.7 with pressure gradient 55, and capsule measure which was 12 millimeters. So equimpression is this is a large thrombus in the main pulmonary artery, dilated RARV, septal flattening, mild to moderate TR with moderate pulmonary hypertension, mild to moderate systolic dysfunction with concentric LVS and good LV systolic function with minimal pericardial effusion. So our diagnosis, this is a case of severe COVID with acute massive pulmonary embolism, with cardiac arrest survival, with history of hypertension, diabetes, and autosomal dominant polycystic kidney disease. In the meantime, other reports come: serum troponin raised, D-dimer, NT-proBNP raised, and ABG reveals type 1 respiratory failure, and duplex study quick survey reveals no evidence of thrombus in the lower limb. This is a very important slide. What the consequence that can happen when the RB pressure overload occur? There's RB dilation, TR, the wall stress followed by RB ischemia, or decrease RB contractility, and ultimately affect the systemic circulation, leads to coronary perfusion decrease and RB decrease oxygen saturation and obstructive shock and death. And this is the very recent algorithm how we treat a case of pulmonary embolism with cardiac arrest in a COVID patient. And this is if there is no contraindication for anticoagulation with the history of sustained hypotension and arrest, this should be patient should be treated along with heparin drip, tissue plasminogen activator. So we did plan our treatment in this patient. A patient was mechanical intubated with mechanical ventilation with heparin drip and IV thrombolysis. Alteplase was given, and short-acting insulin for diabetes mellitus. He underwent rapid recovery, and following thrombolysis, there was extubated 20 hours later, and after he stepped down to the he went to the ward and put on low molecular hemoglobin. He was God actually was him. This is the proposed mechanism how the thrombus formation occur in the COVID patient, because we know COVID is a very much hypercoagulable state. There is a cytokine-mediated diffuse microvascular damage release of when cytokine storm occur. There's a huge inflammatory cytokine followed by hypoxia, dysregulated hemostatic mechanism, clotting factors. So there's a thrombus formation both artery and vein. And literature survey interestingly find that in early French experience, it has found that the pulmonary embolism, there's a 23% occur in severe COVID patient. Even in was optimally anticoagulant, around 13% patient can report a pulmonary embolism. And we follow PICO before discharge. Here the picture shows the focus echo, pulmonary artery completely desolated from the thrombus, and RV function gradually improved, and the TAPSI reveals 18. We underwent a CT pulmonary angiogram. There is no clot, active evidence of clot, but pulmonary artery was dilated. And we discharged the patient on 8th day by giving the rivaroxaban along with other treatment for the next consecutive 3 months. So my take-home message, chairperson, from this presentation is that COVID-19 is a very much highly prothrombotic condition, and acute massive pulmonary embolism is a highly life-threatening condition that can be seen in a significant percentage of patients, of severe COVID patients. Echocardiogram, which is cheap, widely available, easy to handle, and it has a tremendous role for early diagnosis, hemodynamic assessment, exclusion of the differentials, or assessment of the prognosis. Along with clinical evaluation and early evaluation by echo with effective measure in this COVID area, we can, if we start the effective treatment in the earliest stage, we can save the patient, because every life is countable and it is 100% to each individual. So thank you very much to all. We know that vaccine is not available, so mask is vaccine. Everybody should wear the mask properly and advise to others to wear the mask. So we hope for the best for a good environment next. Thank you very much. Thank you for your patience here.